So this is definitely the room if you like listening to people called Nick talking about segmentation. Great. So I'll go through very quickly. We adopted a slightly different approach. Actually, we've talked to Leeds and actually Manchester about this a couple of times. We used the Cambridge Multimorbidity Score, basically just assigns weights to conditions, and those weights are relevant to the risk of one of three things: death, primary care usage, or non-elective admission. And then we just add up the weights. That gives every adult in our system a score. And then what we did was say, okay, everyone's got a score digitally. Essentially, we can line them up, going from 0 to I think about 12. And then we asked a computer model to kind of, could you roughly segment this group? We want everyone to be in one and only one. We're looking for no more than 6 segments, and we'd like them ideally, if possible, to halve in size and double in per person cost. So that's what we're seeing down here. Is segment 1 is our healthiest bit of the population, just over half the entire population, and it's responsible for 16.5% of our total spend. Segment 5, which is what I'm going to talk a lot about today, 3.5% of our population, 21% of our spend. And it's basically what we're able to do is assign everybody in Bristol, Somerset, and Gloucestershire into one of these and then use that to kind of do analysis against various things that we were interested in. Inequality question, there's lots of ways that you can cut it by. This is just by the IMD of the postcode that the person lives in. There's a couple of things here. One is kind of how early this starts to separate. This is our most deprived. So even in their 40s, into diagnosed conditions, it's already starting to separate. You can also see by the 50s, you've got a 10 to 15 year health gap of people in our least deprived areas having the same weighted expectation of burden and health as people who are in our most deprived when they're in their 50s. And again, it sort of indicates it's not necessarily aging that's really the interesting thing, is how we age. And then what we decided to do was look at various bits of healthcare usage. So what this is showing you is non-elective bed days by segment, and just kind of look at the almost vertical line up to the right. So it's 3 months of data in our acute trust. Once you get over 75, that line for 75 just kind of rockets away. There's thousands and thousands of bed days in a very, very small part of our population. And enormously, really interesting as well, this is GP appointments. And this is total GP appointments. This isn't per person GP appointments. So this is segment 1 and 2, which you would expect. That's half our population. That's actually 75% of our population. They're using a fair amount of GP appointments, which is what you'd expect. There's more of. But again, when we get over 75, suddenly our segment 5 are using, by far and away, they're our biggest single group of people using GP appointments, and they're over 75. They're less than 3% of our population. We think that's really interesting for a number of reasons, not least because it kind of, the link between the two sort of shows it's not, which I think came up in one of the main ones as well, is it's not lack of access that maybe is driving a non-elective usage. It's maybe that the services that we're providing these people aren't working, so they're just using all of our services. But it's not that if we just offered them GP appointments, they wouldn't use non-elective care. It's possibly that whatever we've done, we haven't quite set up properly for them. But maybe they need lots of hospital level care. And maybe they're our most comorbid bit of our population. Maybe that's what they need. Actually, what we found was we did a kind of series of spot checks and audits with our acute partners, and 48% of them admitted to one of our major hospitals, University Hospital Bristol. They had no procedure coded against them during an inpatient stay. So that's after they've come in through A&E. They will have had procedures coded to them in A&E, but 48% of them had none, and actually most of the remaining ones were diagnostic or imaging codes. So it wasn't kind of especially complex care. A lot of what they were getting was head scans and chest x-rays. We also, but interestingly, although most of them are actually discharged onto pathway 0, or basically are discharged back home with no kind of follow-up care, 60% of them in an audit were on no criteria to reside, and this is about their complexity. And it's not that they need to be discharged onto something, it's that they themselves are so complex that the amount of admin that someone needs to go through in order to take them out of hospital is really, really high. And then the really interesting thing is the 6-month readmission rate is incredibly high. So what we've kind of talked about here is that these people are stuck on a not very merry-go-round. Even if you improve system flow, you could move them out of a hospital for one particular episode quickly, you're probably still not helping them, because a very large percentage of them are just going to come straight back in. So what can we do about it? Well, there's two things that I'm going to talk about. One was something that we've done, which is actually, again, quite similar in concept to the CVD approach. What we were able to do is, because we could see what people were going into hospital for, and it was largely some sort of infection, a chronic disease exacerbation, or a fall. When NHSE kind of pushed out the anticipatory care list, we took that as an opportunity to bring it together with this insight, and we pushed lists to our general practitioners of saying, here's everyone who's in your segment 4 and 5, and of those, here are the people who have chronic heart failure and haven't had a heart failure review in the last 12 months. Here's everyone who is in segment 5 and hasn't had a flu vaccine, or here's everyone, and kind of added up the weights and then gave them lists of not only people who were potentially in segment 5 and complex, but also insight into terms of, here are things that they are likely to be hospitalised for that they haven't had, that you could pretend, and then able to use the money that NHS England provided to kind of incentivise and help them create a capacity to do something about it. And we were able to, you can't quite see that somewhere, about 30% of them, of the patients we identified in this way, general practice did something about them, or in the process of evaluating, did that then go on to reduce hospital admissions. We also then decided that this kind of, the population who were kind of being sucked in and out of hospital, maybe we should try a new service. So what we did was, there's details there as to the multidisciplinary team that was in there, but basically what we were saying is, pushed out to our ambulance trust and said, in our system, any time a paramedic turns up to someone with who they consider as frail, assessed on the Rockwood score by the paramedic, who they are going to take to hospital, before they take them in, give us a call, and we'll try and see if we can coordinate a community response to that problem and keep them out of hospital, if appropriate. So there was a 1-week trial done in winter. There's a 6-week trial going on right now, and I'll share a couple of kind of insights from that. One is because frailty isn't comorbidity, they're slightly separate, but we can't make comorbidity scores available to paramedics. We have to rely on their clinical judgments. There was a check as to, are we actually getting the people that we think we're getting? And at least in our first week trial, we did, which is great. This is a slanky of like where patients who came through that service ended up. I think the important thing is kind of the plan of home versus inpatient is. These are people that the paramedic was going to take to hospital. In many cases, the paramedic had them in the ambulance and called up and said, I don't think you can do anything about it, but I've been told people to call. And there's about 60% of people were able to stay at home. About 14 to 15 ended up in hospital. Of those, we reckon about 8 could have easily been avoided if we just had a bit more community capacity. So there's lots of like very encouraging things here, that the people that we were seeing were the same people that the data suggested we would see, which is basically, this is a person who has an urgent need, but not necessarily an emergency need. They can be seen in, so long as they're seen in the next 24 to 48 hours in a combined community-based way, they are, that is actually a better outcome for them. And then finally, so that's kind of the service element. The final element that we can do with this is, once you've segmented, you can roll forward your segmentation. So let's look at how many people drift between our segments in the time that we've got, and then roll that forward and see a kind of do nothing scenario. This is a little bit like, I think, what Leicester and Rutland were talking about, and actually there's something maybe similar, around like 4% population increase, but actually kind of closer to 11 to 14% growth in cost, which is the real problem. Our healthiest population is going to shrink, and segments 3 and 4, which are some of our most comorbid, are going to grow the fastest. And the important point about that is, it's, again, as I kind of mentioned at the start, it's not really an aging population that we're worried about. If you age into segment 2 or 3, which not many, but some people do, your healthcare usage is relatively small, even right through your life. If you age into segment 4 and 5, and you age into that point quite early in your life, then that's the thing that we're really, really worried about. So it's not necessarily that you age, it's that you age with comorbidity that's our particular problem. And that, I think, is me done. So there's any time for questions.
That was great. Did anyone have any questions? How have you projected full segments?
Have we projected the movement forwards?
Yeah.
So I can't give you the easiest answer, but basically what we did was said, well, we took the segmentation model at this point in time, and we've got 18 months to 2 years of data previously. Let's look at the rate of intersegmental drift in that period, and then just roll it forward. What we're currently looking at is actually, concerningly, the rate of drift seems to be accelerating. So what we're actually now asking the University of Bath have done the kind of complex modelling underneath that. What we're asking them to do is give us various projections of like, well, if this acceleration carries on, what's going to happen? The other thing I should say, so what we've done is say, okay, well, these are the segment boundaries. Your Cambridge multimorbidity scores are 2 point whatever, puts you in segment 5. Hold that steady and roll that forward. Because if we asked it to always halve in cost and double in size, the segmentation wouldn't change. We've kind of said keep the score the same and then roll forward how many people acquire comorbidities based off the last 2 years of data. As a brief answer, but I can provide more detail.
We've got time for one more question.
Is there a danger of some circularity in this, in that the people that you identify as being in your cluster get more attention, but there might be some reason why people are not being identified. So people with equal need might be not as visible. So unmet need might be reinforced.
Yes, absolutely. And then you've got the problem of attracting attention to segment 5, exactly as I've done there, who are potentially the least amenable to an intervention. And you might want to be thinking earlier on in terms of, I would hope that the main message that the system takes away from it is, unless you're focused earlier on in the process and stopping people moving from segment 1 to segment 2 for as long as possible, you're kind of scuppered. Like you have to get further downstream ultimately, because the point of the last slide was, we already are struggling to cope with what we've got. Our projections are terrifying. The only way to stop that happening is to get serious about prevention and getting a bit further downstream. But yeah, but you are also right, though, otherwise you might attract attention to the wrong end of the thing.
Thank you.
Brilliant. Thank you very much.
Cheers.